Welcome back to Pharmacominds, the place where pharmacology turns from confusing jargon into something you can actually understand. If you're new here, make sure to hit subscribe and join our growing community of learners, because trust me, missing these lessons will leave gaps in your foundations that you'll regret during exams and even more during clinical practice. Let's dive into today's focus: selective beta blockers. Picture this. Adrenaline in your body is like pressing the accelerator of a car. The harder you press, the faster the engine runs, the more fuel it burns, and the more strain is put on the system. Now, in the human body, that accelerator is mainly the beta, one receptor sitting on your heart. Every time adrenaline binds, your heart beats faster, pumps harder, and demands more oxygen. It's great when you're running for your life, but not so great if you're sitting in a clinic with high blood pressure or chest pain. Selective beta blockers come in like a careful driver. Instead of ripping out the whole accelerator system like non-selective drugs do, they simply put a limit on how far the pedal can go down. They specifically block beta 1 receptors in the heart. That means the heart rate slows, the contraction strength decreases, and oxygen demand is reduced. The heart is no longer racing like a reckless teenager on a motorbike. It's now cruising steadily, saving energy, and working more efficiently. Now let's connect this with clinical scenarios. Take angina, for example. Angina is basically chest pain because the heart wants more oxygen than the coronary arteries can supply. If the heart is demanding less oxygen thanks to beta 1 blockade, the mismatch improves and the pain reduces. In hypertension, the same principle works differently. By reducing cardiac output, the amount of blood the heart pumps per minute, blood pressure naturally falls. It's like turning down the water flow in a pipe, lowering the pressure without having to replace the pipe itself. And in heart failure, where the heart is overworked and exhausted, selective beta blockers actually protect the heart from long-term damage caused by constant sympathetic drive. Here's a question many students ask: what about the lungs? That's the beauty of selectivity. Unlike non-selective beta blockers that block beta 2 receptors and risk tightening the airways, selective beta blockers mainly focus on beta 1 receptors in the heart. This makes them safer for patients with asthma or COPD. But don't be fooled into thinking they're perfect. Selectivity is dose-dependent. At high enough doses, even selective beta blockers can start interfering with beta 2 receptors. It's like a polite guest at a party who suddenly gets tipsy. At first, they mind their own business, but eventually they may cause trouble in places they shouldn't. Now, let's put some names to this concept. Drugs like metoprolol, atenolol, and bisoprolol are the classics. Doctors reach for them when they want to control the heart without risking too much lung involvement. That's why they're often referred to as cardioselective. So, to summarize, selective beta blockers primarily block beta 1 receptors in the heart. They slow the rate, reduce the force of contraction, and lower blood pressure. Clinically, this translates into better control of angina, hypertension, and even heart failure. Their ability to spare the lungs, at least at lower doses, gives them an important edge over non-selective agents. If you've made it this far, congratulations! You now understand why selective beta blockers are like skilled drivers who know how to keep the heart engine under control without slamming the brakes on the lungs. This is Pharmacominds, where we make pharmacology simple, memorable, and exam-ready. Don't forget to subscribe, share this video with your classmates, and drop your thoughts in the comments. Every click helps us bring more free learning to students like you. See you in the next lecture.